Hello, Assalamualaikum and good evening to all the participants. Welcome to our fourth series of our Upper GI Surgery Virtual Grand Round 2021. So for those who had been with us from the beginning, you know that this is our fourth series of the our Upper GI Surgery Virtual Grand Round 2021. So with me today, co-moderating this series is Miss Tee from ICANN. So you probably meet her from last week's session. So as for today, just want to share some information that up to today, we have about 620 people registered to participate in this program online. And then so far for last week, we have almost 300 participants who joined the last week session. So for this week, let me introduce you to our Dr. Rama Velayutham, our first year upper GI trainee, who is currently attached with me in Sarawak General Hospital, Kuching. So he was graduated from Master of Surgery UKM, and tonight he will share with us his presentation on his topic on recalcitrant gastric ulcer, when is surgery is indicated. So to you, Rama.
Okay, thank you, Ms. Hashimah, for your kind introduction. A very good evening to everyone. Thank you to the sponsor today for giving us an opportunity to share on this topic. So my topic today is actually a spectrum lying between gastritis and severe complications of peptic ulcer disease, which was already covered by my fellow colleagues, Mr. Su Jin Kim and Mr. Ng Chong Beng previously. The aim of my talk is to define recalcitrant gastric ulcer, understand the main pathophysiology behind recalcitrant gastric ulcer, why is recalcitrant gastric ulcer often a misdiagnosis, and how do we deal with it. Before I continue, I have a polling question here. This is a 46-year-old woman who's diagnosed in 2002 with an episode of upper GI bleed and a pre-pyloric ulcer. She was treated with proton pump inhibitors and seemed to be healed. The patient presented again 6 months ago with epigastric pain and a severe heartburn. She does not smoke or take any non-steroidal anti-inflammatory drugs. Endoscopy confirmed the pre-pyloric ulcer. She has mild anemia and is malnourished. She is Helicobacter pylori negative. Over the course of 5 months, she was repeatedly endoscoped and biopsies were benign with no signs of improvement on high dose of PPI. The question is, what would your management strategy be? Okay, here's the list of questions. You can start polling the answers, and then we will discuss about the answers at the end of my talk. I'll give you all about 10 seconds to pick the answer. Okay, so this is a picture of what is a recalcitrant gastric ulcer. So recalcitrant gastric ulcers is an example of a chronic inflammation, which if it's left unaddressed, leads the patient to go into severe malnourishment and expose them to all the curse of malnutrition. So we will see why that happens. Okay, this is a diagrammatic presentation on the right is on the far right is what you see is a normal stomach mucosa. So the first layer has a mucus with bicarb layer, which protects the epithelial layer, which subsequently below the epithelial layer is where you find the intricate network of blood vessels and nerves, which ensures the alkaline tide is maintained so that the acid and pepsin doesn't erode through the mucosa. Then on the far left, you see what happens is when the mucus and the bicarbonate layer is damaged due to injury, maybe due to H. pylori infection or NSAID, then the epithelial cells are exposed. So when the epithelial cells are exposed to the acid pepsin, they get injured, and then subsequently this erodes through until you come to the muscularis mucosa propria layer, and subsequently what happens is fibrosis occurs. So when fibrosis occurs, it heals with scarring, which prevents healing to the normal tissue and rebuilding of the normal architecture. So this is where the gist here is that when the scarring occurs, you cannot expect the stomach wall to return back to the normal architecture. Okay, how does PPI works here? So PPI basically reverses the delayed ulcer healing by preventing the acid pepsin attack on the healing process. So the healing process, to name some, they have factors like growth factors, which contributes to the proliferation of all the healing tissues so that they can induce healing. But with the acid pepsin, this causes a delay. Okay, so after the pathophysiology, okay, now I would like to interest the audience here with this data from the inpatient, outpatient, endoscopic surgical data from 2017 to 2019 for PGU/PDU surgeries in our country. You can see here that we have performed overall more than 1,000 ulcer-related surgeries under MOH for every individual year. Okay, this is another IOES report for 2019. Shows here the number of PGU/PDU which required partial gastrectomy for individual tertiary hospitals in the country. Each bar represents one hospital, and each hospital performed between 1 to 7 gastrectomies. 4 hospitals, you can see, had 100% mortality rate, while a number of hospitals had between 29 to 67% mortality. Total procedures were 62, with overall mortality rate being 50%. This result might be underreported, but it shows the burden of the disease of peptic disease. Okay, doing emergency gastrectomies in malnourished, chronically inflamed patient is resource intensive, and they tend to do poorly with high mortality risk. Most patients will require post-op or pre-op ICU and critical care services. This is naturally reflected in the mortality outcome of the result. We surgeons sometimes can't choose the patients that we wish to operate, sadly. Okay, I like to share a case here from my center. This gentleman, TS, is a 51-year-old farmer who is a chronic smoker. In 2003, he had an enteral gastritis with a H. pylori positive. He completed eradication. Unfortunately, in 2015, he had a perforated enteral ulcer, underwent laparotomy and a non-definitive repair done. Repeat OGDS post-surgery noted a large ulcer at the incisura with a deformed pylorus. He was treated with PPI and planned for a repeat OGDS. Unfortunately, we lost him in follow-up. Then from 2018 to 2020, he had multiple admissions to the district hospital for iron deficiency anemia, where then he was referred to us for another OGDS which showed a non-healing incisural ulcer, and there was food particles seen in the stomach during the scope, and he was given multiple courses of PPI again. Finally, in October 2020, he came again, and this time with hematemesis and melena with an episodes of hypotension. We did an OGDS, noted a large circumferential enteral ulcer extending to the incisura. We also did a CT-AP during this admission to assess the extent of the ulcer. This is the image of endoscopic view of the ulcer, which extends from the antrum to the incisura. It's another view of the ulcer, angry, malignant looking, fiery lesion. This is the CT axial view of the stomach. You can see that the body and the antrum is thickened. You can't see a clear pyloric channel. There's multiple enlarged perigastric nodes. This is the coronal view. You can see the stomach is thickened and it appears dilated, and the pylorus is deformed. Recalcitrant gastric ulcer is defined as an endoscopically proven ulcer greater than 5 mm in diameter that does not heal after 8 to 12 weeks of treatment with proton pump inhibitors. This man has a recalcitrant ulcer with complications of recurrent GI bleeding and gastric outlet obstruction. This man fulfills the definition by virtue of having a non-healing ulcer since 2005 with repeated endoscopies and prolonged PPI therapy. He also is manifesting complications with recurrent GI bleeding and gastric outlet obstruction, contributing to his chronic inflammation, leading to malnourished state and poor quality of life. This is a failure of identification. So yeah, subsequently, our gentleman went through a subtotal gastrectomy with a Bilrod 2 reconstruction, intra-op dense adhesion between previous laparotomy scar and ulcer. There was a sealed perforation of the enteral gastric ulcer which has eroded posteriorly with large excavating base formed by segment 2 of liver, duodenum, head of pancreas, and the transverse mesocolon. Post-operatively, he had duodenal stump leak requiring re-rhabdotomy and watch-out. He was discharged well on day 44 post-op. HPE showed chronic gastritis with ulceration. We kept him longer in ward to make sure that he was out of the woods, just as he came from an interior part of Sarawak and access to medical care is limited. So what are the consequences of a neglected recalcitrant gastric ulcer? Commonest presentation is due to chronic anemia, and patients are often labeled as iron deficiency anemia. This is actually the reflection of malnourishment and, to a certain extent, the bone marrow failure. Other presentations are GI complications like perforation, gastric outlet obstruction, which can be challenging to treat, and frequently this group of patients will require surgical intervention. Acute bleeding will need urgent endoscopy to decide on the next intervention. Most of the time, endoscopic finding for a recalcitrant gastric ulcer will be large, irregular ulcers that are impossible sometimes to secure the bleeders with the conventional tools like clip and diatemy. In my center, we have a dedicated, reliable interventional radiology service to assist us in managing bleeding. Elsewhere, especially in district hospitals, surgeons may need to consider whether to do a definitive or underrunning based on the endoscopic finding. If the ulcer looks deep, chronic, do not repeat unnecessary scopes and proceed with the definitive surgery. A point to add on gastric outlet obstruction, besides surgery, you can also consider pyloric dilatation, but be cautious with dilating a fibrotic scarred tissue, especially in recalcitrant gastric ulcers where the patient had possible previous seal perforation. Dilatation can be done up to about 16 mm. Patient with more than 2 dilatations, however, at higher risk of failure and would suggest to require better to go through a surgical intervention. And lastly, but not least, recalcitrant ulcers has 4% risk of malignant transformation. An image of a gastric outlet obstruction in a patient with recalcitrant gastric ulcer. Patients normally present with frequent vomiting. They also will have severe electrolyte imbalances and dehydration along with malnourishment secondary to the chronic inflammation. So before embarking on OGDS, it is good to make sure that the stomach is emptied of residual food particles. Nurses must be trained to do effective lavage, use an appropriate size of NG, 14 French or 16 French, and monitor for the risk of aspiration pneumonia. This is an image of a pyloric stenosis. You can see the surrounding tissues are irregular and chronic gastritis changes. Here, I would like to show how we do a endoscopic insertion of Naso enteral tube. So you can see the guide wire is placed as distally to the DJ. Now the silicone catheter is railroad via the guide wire till DJ flexure until all this is done under the direct vision via the scope. Finally, placement of the silicone catheter with a small lumen proximal to the opaque marker used to gastric lavage and aspirate the stomach fluid. The X-ray shows the final position of the silicone catheter, which is at the DJ flexure. This drawing shows of a typical size of an obstructed stomach where the ligament of Treves is lying almost at the pelvis, and the greater curvature extends to the pelvis, and you can see the pylorus looks angulated. This silicone catheter has two functions. One is to decompress the stomach at this area, and two, to provide the jejunal feeding at this end. So why do we fail to identify patients with recalcitrant gastric ulcers? Number one, endoscopic training. Sometimes we fail to identify the non-healing ulcers, the characters and the features, lack of awareness, failure to identify gastric outlet obstruction, the retention of undigested, partially digested food in the stomach. Number two, failure to identify patient malnutrition. These patients normally do not thrive. We as clinicians assume adequate nutritional intake as long as the patient can eat. We fail to appreciate evidence of malnutrition until it's too late when they present with obstruction and perforation. For example, in this image on the side of my slide, you can see that the mucosa of the stomach, it is chronically inflamed and it is practically non-functioning stomach. So patient will end up being malnourished. There is a lot of online websites that offer free coaching for OGDS like Higan to improve your endoscopic skills. So this is the website where you can go e-learning for endoscopy. Okay, so fine. Next, what are the indications for surgical reconstruction? Number one and foremost, non-healing ulcers that fulfills the definition of recalcitrant ulcers, which does not respond to PPI, and evidence of complications such as recurrent bleeding, gastric outlet obstruction, iron deficiency, anemia, and malnutrition. Based on the literature review, there's only one meta-analysis so far that is published in the Cochrane review that compares between surgical versus medical management. It is concluded that there's no randomized control trial to compare surgery versus medical treatment for recalcitrant gastric ulcer. Thus, there is a need for a large-scale study in this topic, especially in our country where recalcitrant gastric ulcer is quite common. As a surgeon, my take is the fibrosis that occurs is irreversible and the disease segment need to be removed to encourage healing and end the chronic inflammation. This is a flow chart to show how you can manage the patients who come to you with recalcitrant gastric ulcers. You can try an anti-secretory therapy with PPI, either intravenous or oral, for about 8 to 12 weeks. Gastric ulcers, sometimes you tend to give longer period. During the treatment, you assess the etiology for the peptic ulcer disease, discontinue aspirin, NSAIDs, eradicate H. pylori and confirm the eradication, perform a repeat OGDS. If the ulcer persists, refer the patient to tertiary center with appropriate facilities and experience to handle for definitive surgery. There are several different techniques to do a gastrectomy and obtain an effective food intake with a low post-operative morbidity. In recalcitrant gastric ulcer, the aim of the gastrectomy is to remove the disease segment to end the chronic inflammation and prevent complications. Number two, to reduce acid secretions. So the options that I've listed here, number one is enterectomy, which eliminates the hormonal secretion of gastrin. Distal gastrectomy, which removes less than 50% of the stomach, which eliminates gastrin and also part of the parietal cells. And subtotal gastrectomy finally reduces the basal acid output to less than 70% at rest. Sometimes when you have to consider lymph node dissection, if the ulcer appears to be potentially malignant, and all perigastric and perivascular nodes should be dissected. Once you have done a gastrectomy, we have to think about the reconstruction. So it's always a discussion going on between Roux-en-Y and Billroth-2. However, studies shows that similar short-term complication rates between both of these procedures. So it is largely surgeon preference, patient factors, and the extent of resection that you can choose to decide which reconstruction. However, long-term issues are associated with Billroth, where there is a risk of gastric remnant malignancy, malignant ulcers due to the chronic reflux. There is other more rare issues like gastric emptying disorders like afferent loop syndrome, Roux stasis syndrome, which are rare, but one have to keep in mind. To most upper GI surgeons, Roux-en-Y reconstruction is the technique of choice based on simplicity and the satisfactory nutritional results. End of the day, the deep consideration must be put on for a well-vascularized and a tension-free anastomosis. Here's a paper by Li Rongzi, did a meta-analysis comparing both reconstruction between Roux-en-Y and Billroth. His result shows that intraoperative time and blood loss is increased in a Roux-en-Y. Post-op mortality is the same, leak rate is the same, delayed gastric emptying is increased in Roux-en-Y, esophagitis and gastritis, malignancy risk and dumping syndrome is higher on a Billroth-2 reconstruction. Finally, recommendations. We must not fail to identify recalcitrant gastric ulcers and their complications. We must intervene early before the malnutrition occurs due to the chronic inflammation. Surgical reconstruction must address the intent of resecting the diseased segment and restoring the alimentary continuity. Chronic inflammation and stomach failure is preventable if we can pick it up early. Okay, can we have the polling results? Okay, so the polling results shows that there's a draw. 43.7% of audience offer surgical intervention with reconstruction, and another 43.7% refer gastroenterologists to work up for more rare cases of non-healing ulcers like Zollinger-Ellison, Crohn's disease. Okay, that's interesting. Yep. So that's the end of my talk. Thank you.
Okay, thank you, Rama, for the talk and then for sharing the cases with the audience for tonight. Before I forgot, because it was too exciting in the beginning, I forgot to share about the housekeeping announcement for the tonight presentation. So for the one who first time joined us tonight, so just your outgoing audio will be muted, will be not necessary anymore. So the webinar is being recorded for internal use purposes. So your participation serve as consent for the same. So at the end of this series, the e-certificate will be sent to you at the end of a webinar. So you can use it to claim your point as proof of attendance via NSR or your CPD to MMA. Okay, after each of the session, you will receive a link on the survey to your email, and we highly appreciate if you can actually reply and to the survey, and then it can help us to improve our outcome. Improve for subsequent webinar, and also how we perform subsequently in the next series. So if you have any question or on sponsor related, you may mention in the survey, and we will send the sponsor to get you in touch with you after the presentation. Okay. So before we go back to our Q&A session, we would like to share some of the video from our sponsor for tonight series. Okay. Yeah. So We are back to our Q&A session. So Tee, probably you want to bring up the first question to Rama.
Yeah. Thanks, Rama, for the presentations again. I think there are some attendees who would like to clarify with you if you know, after 8 to 12 weeks of proton pump inhibitor, is there a role of another rounds of 8 to 12 weeks before you embark into either surgery or further workout? What do you think, Rama?
Okay. Yes. If you have given a 12-week course of PPI and you think that there's some response to the ulcer, you can give another 12 weeks of PPI. If there is still in the literatures is still mentioned that you can give another 12 weeks of PPI, which means maximum 24 weeks. And during this period, importance must be put into whether you have eradicated the H. pylori. So once you have, if the patient was positive before, you want to do, you want to reconfirm, and you want to make sure then you want to make sure patient is not taking NSAIDs and all the other common risk factors, which are H. pylori, risk and NSAIDs. This must be checked in the patient's history. So basically, history is very important. Yeah.
Okay, so basically what he meant is, because some patients, they actually have slow healing, you see, especially when the old patient, they're on multiple medication. So the rule of 12 weeks maximum is not a straightforward rule. Okay, in general, we see the ulcer is healing at 12 weeks, but some patient, you can see at 12 weeks, there is a sign of healing, but it's not completely healed. So maybe this kind of patient, you can actually give another round probably, but then you have to make sure that the suspicious of malignancy is already ruled out. Because some ulcer, if you think the ulcer is suspicious, so you shouldn't be giving another 8 weeks of PPI, because that is just delaying further treatment for the potentially malignant ulcer. Okay?
Yeah. I also agree with Dr. Hashimah. I think unless I think other like Dr. Rama, you mentioned, the compliance, patient smokes, there are some risk factors still present. Otherwise, I'll still stick to 3 months max, because otherwise another 6 months, most of the time it will just probably delay. But of course, if the compliance is a problem, and the patients, because compliance is an issue sometimes, most of the time, and then if they still smoke, maybe there's a possibility. Otherwise, I think we should still try to stick to 3 months, because another 3 months probably would just delay. That would be, I think, my opinion. Hi, Rama, do you have, because you mentioned about malnourished, in patients, especially all these recalcitrant ulcer, because they just don't eat well. When the ulcer doesn't heal, can you share with us what about your strategy in elderly patients, especially in this group of high risk patients, when you have a recalcitrant gastric ulcer? Do you have any experience when you're coaching, dealing with this group of patients?
If basically we go back to the principle where when they have these recalcitrant gastric ulcers, the pathophysiology here is fibrosis and scarring. So you want to expect the PPI to resolve the healing fully, because it's fibrotic. There's no more tissues to induce healing. So if it's bad and there's already complications, we tend to optimize them with either enteral or parenteral nutrition, and then subsequently plan for a definitive surgery. Yeah, that's my opinion on how to address these bad recalcitrant ulcers.
Okay, so what if there's somebody asks, what if, like, when you see the patient with the recalcitrant gastric ulcer, as usual, most of the time, because we see there's a sign of non-healing, people usually take a biopsy. But let's say your first biopsy come back as benign. So when do we need to repeat again? If the biopsy, will be happy with the result as benign, or will you you know, if you
Okay.
think is anything suspicious, would you keep on repeating? Like there is sometimes there is a incident that people keep on repeating, but it keep on benign until, for example, the case that you shared earlier.
Yeah.
Every time the patient came in, the biopsy was repeated, and then after that, this is a benign, so people were discharged with PPI, and then after that, it keep on coming over the almost 10 years. It's persistently benign, and people just keep on doing repeating scope. So when do we need to put a stop on this, or when do you be happy with the biopsy result?
Okay, biopsy results are two-way sword. So, like I mentioned, there is a risk of malignant transformation or a hidden potential of malignancy in all these chronic ulcers. That you don't know when the transformation. Sometimes after 5 years, sometimes earlier. We don't know. So, your biopsy, the area you take might just show chronic gastritis with chronic gastritis changes, with maybe intestinal metaplasia and things like that. But that is why you need to have a discussion with people who are more experienced, and then you have to, like in my algorithm I put there, if you think the ulcer is suspicious from your experience, it looks like, you think a patient should go for definitive surgery earlier, even if your biopsy is benign. I strongly discourage repeated biopsies. Maybe a course of PPI for about 8 weeks and you don't see much improvement, I think definitive surgery is the way to go.
Okay, so I think it's safe to say that because this topic is on recalcitrant gastric ulcer, I mean, if the biopsy come back as malignant, it's pretty much straightforward. Everybody just referred for surgery. So what happened is, if your biopsy is keep on coming back as benign, so how long, how many times do you wanted to repeat the biopsy? So this is when the definition of recalcitrant gastric ulcer come in. So this is when, after repeated biopsy, like we give this time, there's a time frame that we give up to 12 months, the most that you continue after that for another 8 weeks. So at this time, even if the biopsy is come back as benign, we should actually embark into the surgical intervention. So this is when you shouldn't wait until you satisfied with the biopsy to be malignant, because obviously the healing is not going to occur. So before the next complication happen, because as you know, the complication might not be malignant transformation, it might be bleeding, it might be perforation, it might be obstruction, might become earlier before it's malignant transformation. So this is when the surgical intervention come into view. Okay, so right. So for the next question,
I think I can just, sorry, Hashimah. Yeah, you want to go ahead
yeah,
first?
because this is just related. So it's very interesting to just ask this
Yeah.
question. So if a recalcitrant also develop obstruction, okay, so now how do you decide whether you want to do a resection, mean a gastrectomy, or you just want to do a bypass? This is also commonly happen, and commonly probably people outside there probably think, should I do a gastric or should I just a bypass because it's just an obstruction? So how do you decide, to gastric or to bypass?
Okay, if I mean, go back again to the principle. Ideally, to prevent the chronic inflammation and the disease segment, ideally I would try my best to do a definitive surgery. But if the morbidity of the surgery, let's say it's ulcerated, perforated, erode into the pancreas, and it's like a mass there, which is gonna cause a morbidity for this patient who sometimes they are very elderly patients. I would tend to do a bypass rather than going for extensive resections. That's my take on this. But ideally, I would go for a definitive surgery.
I mean, sometimes I know for gastric, I mean, looking at your slide that you share with us, gastrectomy, in a certain center, maybe the mortality rate is high, but I think for a definitive, I mean, probably for us, we are more well trained. I'll still go for. I mean, I disagree with the bypass. If possible, we should go for a definitive surgery, because you need to remove the antrum, and then that will be better for quality of life. Because of course, if really dire emergency where the patient is, I mean, at the extreme conditions, and you want to consider bypass, there is possibility. But I think for us, most of the time, if the patient is stable, obstructions, most of the time they presented rather in a semi-emergency way rather than a very emergency way. So if you think it is a recalcitrant ulcer, I would say that you can initiate the initial treatment, but probably the best thing is just to refer to another well-established center, and then for us to manage, because I think definitive surgery would be better than just a bypass surgery. What do you think, Dr. Hashimah?
Yeah, because in this condition, usually I will look at the patient, because as you know, chronic obstruction mean there's a chronic ulcer, the long-term scarring and everything. Eventually, the malignant transformation can be occur in long term. So personally, I will look into is like, if the patient is young, it's going to live a little bit more longer. So probably gastrectomy is a better option, because if not, it will come back to you maybe intense when you are like super upper GI surgeon, come back, become your problem. Okay, so but is in elderly patient, probably not so fit, probably it's just adequate to just bypass the patient. Okay, so in relation to the question, there's somebody asking whether would you consider dilatation of the pyloric stricture in patient with gastric outlet obstruction following this recalcitrant gastric ulcer? So following the, in relation to the question, because the obstruction is mainly due to the very scarred tissue. So it's not as easy as that to dilate the scarred tissue. Okay, so we never dilate gastric outlet obstruction from this recalcitrant gastric ulcer. So most of the time it doesn't work, and not that we ever try, but if you look into the principle, the pathophysiology behind it, so it doesn't work. So don't waste time, because I think there's some people who actually try to dilate. Maybe you'll be successful the first time, but trust me, they all come back, and usually they come back to us. So this is why I know they fail. Okay, so right.
Maybe we can go to the polling questions. I think that Dr. Rama made. I think I would expect most of the attendees belongs to the surgeon group rather than the gastro group, but we're quite surprised that 44% of for a recalcitrant ulcer, 44% will go ahead with the surgery, but 44% will refer to a gastroenterologist friend, to investigate further. I think related to the questions that some of the participants had also, what is your opinion? Any further workout that you will embark on, or you are thinking on what kind of workout that you would expect a gastro to work out for this group of patients, Dr. Rama?
Okay, number one, as we know, the commonest cause is H. pylori. So if I am going to refer to them, maybe I want to get a further input on the second line. Maybe the patient we are treating, maybe this is a resistant strain, or maybe this is different organism, which then something more complicated management H. pylori, I would refer to them. And then let's say I want them to work up further for Zollinger-Ellison, and then other rarer causes, eosinophilic gastritis and things like this, probably there is a role. But if this is a very suggestive history of peptic ulcer disease, and there's all this scarring, and as what Ms. Hashimah said, the segments are all diseased, I think you're just wasting time.
Okay. Right. So this is also a very common question and a very common practice that we see in every day. What do you advise to all the general surgeon outside there? How do they follow up on the post-perforated gastric or duodenal ulcer after the initial simple repair? because a lot of these general surgeons, they tend to miss out a post-repair complication of PGU and PDU like gastric outlet obstruction or even development of malignancy. Basically, when after surgery, when the patient coming back to the clinic, is usually seen by other people. So sometimes you might miss what is the potential complication. So how would you advise on these people to, how do they follow up all this post-PGU repair?
So, okay, if you do a non-definitive repair, post-PGU repair, that's not the end of the whole pathogenesis. You have not addressed the whole matter yet. So, yes, the immediate management has been done. Patient is well now, but you need to do a repeat scope. You need to assess the ulcer, and you have to follow up this patient, because you must understand, if the H. pylori eradication is not complete, patient might have a recurrent ulcer along the year. You don't know when the thing can onset again. So if you miss the patient, they have recurrent ulcers, and then this what happens, they come back again 2 years, 3 years, 4 years later. So you have to have a very clear idea about that PGU, the initial repair, and you have to follow up with scopes, and you have to ensure that it's healed, and follow up the symptoms with the patient in the clinic to make sure that they are symptom free. And yeah.
So do you consider surgery in recurrent pain for recalcitrant gastric ulcer in patient who is taking long-term anti-platelet drugs?
Yes, as I said, I mean, whatever, either they are taking anti-platelet drugs, or they're taking steroids, or they are, whatever immunocompromising drugs. If they have recalcitrant gastric ulcer, did not respond to PPI, I will consider definitive surgery.
Again, some questions on PPI related to last week. For recalcitrant ulcer, right? Like for example, I think just now, yeah, I think Dr. Rama have mentioned, some advice to the general surgeons, and after you simple repair, and how should you follow up the patients. What about the durations of a PPI? After you do a simple repair, how long do you continue? Do you continue them as it's 12 weeks, or how do you? What is the durations that you would give them, prescribe them PPI?
Okay, generally the principle is the ulcer heals at about 3 mm a week. So this is in a very good condition, where all the acid pepsins are not eroding into all the healing tissues and all that, about 3 mm a week. So if the ulcer is, you have an idea how big is the ulcer. If it's a 1 cm ulcer, 3 weeks, then you give a PPI 1 month to 6 weeks will be adequate. But if it's an ulcer which is 2 cm, there's no point. I mean, if you ask my opinion, and then the ulcer looks 2 cm is big and chronic, I think definitive surgery. You have to talk to the patient about definitive surgery, not just depend on PPI.
Rama, when the patient is having a chronic pain, what do you think is the cause of the chronic pain?
Okay, that's it's a difficult question. Okay, I'm thinking,
So,
what I can think of is that most likely this patient has a perforation already, which is sealed off and eroded through the pancreas, and so causing some sciatic, celiac pain or something. That I can only think of a sealed perforation. I can only think of sealed perforation, which has eroded.
okay, yeah, most of the time when they have a sealed posterior perforation, the chronic scarring with the pancreas covering the base of the ulcer, this is one of the main cause that we see in the cause of chronic pain in the patient who have this recalcitrant gastric ulcer, which sometimes when you do endoscopically, probably you cannot identify that as a pancreatic tissue because of the scarring on top of it. But if you were to perform surgery, then you realize all the base of the ulcer you have been seeing endoscopically was actually a pancreas. Okay, so this is actually what we commonly see when we do a surgery for this recalcitrant gastric ulcer. All right.
Do you see that very often, Dr. Hashimah, in your center? I mean, what kind of recalcitrant ulcers that you see, whether they have obstructions or they have this kind of seal perforations or bleeding?
Probably I can ask my trainee who have been with us for like less than a year now.
Yeah.
So how many months you're in Kuching now? It's like 6-7 months. How many of case of recalcitrant gastric ulcer have you seen?
Yeah, it's I think in a week at least 2 lah. So
No lah,
the one that I mean we have operated since I came until now, operated at least about 9 to 10 cases recalcitrant gastric ulcers, and then we also have cases where we are giving we trying I mean they are on PPI now, and you know we will reassess them. That's another 4 or 5 cases. So that shows the number in 6 months about 14, 15.
Yeah, we have a lot of these kind of cases. I mean, at least in Kuching, I do not know elsewhere. So right, this is why we brought up this topic to share with everyone else. Okay.
And interestingly, they have multiple scars in the abdomen.
Yeah, but what about the, you know, if you do like definitive surgery for them, what is your preferred recon? I mean, do you do Birof too, or Ruai, and what do you consider? I mean, which one to choose for such case, Dr. Rama?
Okay. So basically, if we do a distal gastrectomy, sometimes I mean okay, if we do the remnant stomach is big, then I think I will consider Pyloric 2 reconstruction. But if you're almost like a subtotal, you are taking almost 50% or more of the stomach, then I would go for the Ru and Y reconstruction because worry the reflux.
Do you usually do, like, you know, either hand sewn or do you staple them, or, you know, what is your
we have both. I mean, I tend to hand sew, but when I do with my consultant, then we use staplers. So I get a mix of both.
Because we do 3 cases in 2 to 3 cases, so you cannot afford to hand sew.
Yeah.
Do you routinely do like sorry?
Yep. Carry on, Misty. Carry on.
Yeah, I think one of the participants also asked, you know, besides the recon method, and do you routinely do a brow jejunal because there's a risk of reflux, especially in those who had Birof 2. Yeah, do you always do a JJ, or just like a normal loop GJ?
No, we just do a Pyloric 2. No, I mean I don't do a brown procedure.
All right.
Okay. Yeah. So Rama, let's say if you want to do a gastrectomy for this recalcitrant gastric ulcer, you see, even though the HPE might be benign on your biopsy, the final HPE, it still could be malignant. So how would you determine the proximal margin for definitive surgery? How much to cut?
Okay. So I mean if what I will do is, I mean, endoscopically I know where's the extent of the lesion. So if it's if it is, I try to at least take a good margin lah, at least about 5 cm or at least a minimum of 5 cm margin from the ulcer, and make sure that the resection is at the area where the stomach is healthy lah. So because there's no way I can say it's malignant. My intention is for benign, so that's the only way I will plan my resection. At least about 5. If I can take 5 cm lah.
So would you like to share with the audience what is your post-operative management of patients who undergo definitive surgery for recalcitrant gastric ulcer in terms of antibiotic duration, whether you want to give TPN, or when do you want to start on enteral oral feeding? Would you like to share with the audience? Because some people actually wanted to know how does you do it differently.
Okay, how we do it is actually we are quite aggressive here in Kuching. So by day one, we already, most of the time after definitive surgery, we allow patient clear fluid. There's no nasogastric tube. Most of the time, no nasogastric tube. By day one, we start clear fluid. We assess clinically, patient is passing, is okay. Then by day two, we already start oral nutrition support. And by day 3, day 4, they already start them on soft diet, and they should be good to go by day 6 or day 7 if they don't develop the most dreaded complication, duodenal stump leak.
Does the patient, let's say the patient develop duodenal stump leak, does it change in a way that you're managing the nutrition of the patient?
Okay, that is based on two factors. One is whether patient is septic or not, and number two, the output. If patient is septic, yes, I may change the patient management. And number two is if the output is high, more than 500 cc, going up to 1 liter, I might withhold the enteral feeding and consider total parenteral nutrition first, and see the response for some time. Most of the time, eventually the output reduces, and then I can restart enteral feeding. Most of the time with ONS first.
Yeah, I think we are almost coming to an end. There are still some questions, but we try to answer some. But I think there's one questions early on which pop up. Probably I'll just ask for your opinion. Since there's a possible refer to gastro, besides doing further workup for all these non-recalcitrant ulcers, do you think that they could help us in terms of giving some therapeutic, interventions like dilatations? Then I think you mentioned that. Do you think that it is good options to refer to our gastro colleague?
I'm against dilatation because the pathophysiology of the disease is scarring and fibrosis. So chances are sometimes you dilate and then you will see a perforation there. I mean, you can try up to that. What I put in my pointer just now was that you can 2 attempts of dilatation. You can go up to 15 mm. I think the balloon is 15, 16 mm. But if, like what Ms. Hashimah said just now, most of the time probably will fail. They will recur again. There's no point keep on dilating, and the chronic inflammation is going on. So what's the point?
Yeah, that's right. I totally agree. I mean, it's not that because I'm a surgeon and then I don't believe in my gastro colleague, but then I think we have to recognize that it is a recalcitrant ulcer and we deal with it early, stop all the, of course we can optimize the risk factor, but eventually there are a lot of them who need the surgical interventions. Yeah. Dr. Hashimah, what do you think?
Yeah, I don't have gastroenterologist colleague with me. So basically everything is on me. Yeah. I'm waiting for my gastroenterology colleague to come and join me soon. Okay, Rama, this is a lot of interesting practice and question. Do you regularly pass the Rouse tube beyond the gastroduodenal anastomosis of gastrojejunostomy anastomosis? So that you can initiate the early feeding. I mean,
as I told, I follow my consultant. There's no.
You can answer based on your practice before joining.
Okay, I since I joined the program, no more, no more. I mean, before this, yes, I do that lah. It gives me a security lah, sense of security. But I think, not necessarily. I've seen enough outcome, and I think I move away from that practice.
Yeah, I think it's pretty much, there's a lot of study already proof that early feeding in the gastrojejunostomy anastomosis is not a problem. Okay, so the thing about something that I do not, I mean, of course you can actually put the nasogastric tube beyond the anastomosis. Is not a big problem, but there's always issue in our local hospital and everything. The next day the Rouse tube will be out, and then the feeding will be interrupted because the nurses or the doctor would don't know what to do after that. Or if not, they will not following orders and everything. And sometimes I do think that the Rouse tube, if you leave it too long, bypassing the anastomosis, sometimes it actually can compress or ulcerate or, and the anastomosis itself. So not my favorite practice of putting the NG tube beyond the bypassing the anastomosis and post gastrectomy, even the total gastrectomy.
I think
One
probably we
last
are
question.
Yeah, one last question.
Any questions? I mean, there's a lot of questions here, but I think it will take
Yeah,
time.
maybe we can. I think we can just touch on the last bit. You know, sometimes certain patient who has I've been post gastrojejunostomy, I think, and we encounter patient who develop a chronic ulcer or non-healing ulcer over the anastomotic site. Do you have any advice for this kind of patients, or how we should manage this kind of patients? I think this would be quite. I mean, for this GJ or anastomotic ulcer. Do you have any opinion on that, Dr. Rama?
My opinion, if it is a recalcitrant ulcer it's a marginal ulcer which is recalcitrant, I think if it's subtotal, then I will consider doing a total gastrectomy for the patient. That's my opinion.
So actually, most of the time, the ulcer, the vaginal ulcer in all these recalcitrant ulcer, they develop if you did not perform adequate resection. You see, in ulcer surgery, is the main important thing is you have to completely remove the antrum. So sometimes, if you see some people do gastrectomy, just remove a distal part of the stomach, really distal gastrectomy, really distal. So there's still enteral tissue left. So this is most commonly the cause of the marginal gastric ulcer. So this kind of patient, usually they need the resection and then reconstruction after that.
Yeah, I think I totally agree with Dr. Hashimah. The retained antrum or the inadequate resection is one of the problems that we face, because as we are more junior last time, I think, or sometimes as a general surgeon, we probably don't really dare to cut too much. But I think that is probably the pitfall that we have made usually. I think this is coming to an end, or probably any closing remark before we remind the participants about the next week topic.
Rama, anything you want to say to the participant?
No, thank you for spending the time to listen to my talk, and really appreciate it.
Okay, so before we wrap up for today, we'd like to thank you, Johnson & Johnson Malaysia, for sponsoring this week session. So before we leave, so we would like to invite you to join us for our next week session. Will be hosted by Hospital University Kebangsaan Malaysia. So we welcome again Dr. Sekapan to present on the DJ flexure tumor, GIST or desmoid, the emergency dilemma.
Yeah,
So
I think I have I have a last sentence for this topic, because it is quite common that we see recalcitrant ulcer. So I still think if the patient does not present in a very emergency way, I think there are quite a few UpperGI centers, for those that you can't really manage it, do refer to us. I think the patient definitely would get better quality of life, and if anything you're not too sure, just call us up and try to prevent further or long-term PPI and or further complications for all this group of a patient. I think that would be my last advice for all the attendees or participants today.
All right. Any further question, you all can actually email us if you want to know more, because and we look so friendly. Or if you just too lazy to manage, you can just refer to any one of us. Okay, with that, we'll say good night and have a good weekend coming ahead. Okay?
Okay, thanks.
Bye.
Bye, good night, everyone.
Good night.